I had a class on validation, which in epidemiology, as you can imagine, it's about specificity, sensibility, ROC curves, and things like that. But my professor, he had a crush on psychometrics because he used to work with latent variables. And then he was speaking and explaining, and then I was thinking, oh gosh, I think we have a lot of issues to discuss in oral health related quality of life, because many different things that I had in my mind, they didn't fit each other. So I got this different literature, which was quite enlightening. And then I think I can learn more about that. And quality of life was the main topic I've been working with latent variables, but not the only one. So as Hilda has said, we have been going through all these 6 topics, and some of them are rather basic, just to be sure we are all in the same page. And I have here the presentation of the slides from Mateus. I use Ubuntu, Linux, and he uses another system. So the file came from Mateus. It's not configured, so some slides are not going to look very nice. Well, so let's start with concepts. Be sure we are all in the same page for these concepts. What are latent variables? And latent variables in many textbooks, they are described as abstract concepts, things that cannot be measured directly, but they are very common in social sciences and very common in public health. It's something like, well, if it's abstract, how can we be sure they do exist? Perhaps you have seen this TV program, The Asian Aliens, from History Channel. And once I was watching this episode, it was about, how do you know aliens exist? And then they said, well, it's because the pyramids in Egypt is a so high technology, they could not be built by the current technology, so it has to be an alien technology, because they could not see the aliens. There's no actually proof that could be linked to them, only the output of the consequences of aliens being in the world. And then I realized, okay, these guys, perhaps they learned something about latent variables, because that's the concept of latent variables. If we look for things that in our daily life, like happiness, how do we know happiness exists? And then you're going to say, well, it exists because I can feel it. Perfect. That's how a latent variable exists. We can feel it, but I cannot see what others are feeling. But people, they may express their happiness in a different behavior. They can smile, they can make signs in their faces with their eyes and the cheeks, and they have a lot of facial expressions. So we can recognize a happy person when we see them. But see that only smile is not enough, because people might smile because they are nervous or afraid of something. So smiling is part, but not everything. So it's not the only behavior or the only sign. But smiling is something that I can see and I can count, and it's more concrete stuff. So that's how we measure latent variables. And that's how we know they exist, because they have consequences. And this idea has been also described in 1997 by Peter Fayers in one of his classical papers from quality of life research. And in that same paper, they have these 2 distinct models. And we are talking about, let's say, theoretical models to build instruments, right? So in one model, which is figure 1, we have what we call formative model, in which the items that are part of the instrument, they are the causes of the latent variable. In this case here, this bubble is the latent variable, and these squares or rectangles, they are our concrete measures that we can measure. But let's be clear, that's not the best way to measure a latent variable, because we assume that the consequence of pain will be lower quality of life, and vomiting, and diarrhea, and so on. So we have this strong assumption. But we have also figure 2, in which we have a reflexive model, which is all the indicators, they are an effect, a consequence of quality of life. So people may have anxiety because they have low quality of life. That's a consequence. That's the best way to measure or to build an instrument, right? And again, I'm saying we build an instrument based on these ideas and concepts and models. We don't find an instrument. It's not, okay, let's go to the woods and search for some quality of life instrument in my database. I have several, variables. You need to select specifically the items based on the concepts that you have. And the concepts are, of course, a latent variable, which is abstract and cannot be very meaningful on its own.
Roger, can I ask
Yes.
you to delete the participants from your slide, because they're telling they can't see the whole screen that you are sharing. So we can
Yes.
delete the participants. Sorry, I'm interrupting, but I'm seeing the messages on the screen.
Thank you very much. I mean, I thought it was only for me. That's why I didn't.
Okay. So no, because they're seeing.
Thank you. And please stop me at any time. I mean, if you have some doubt, because I mean, I'm just
And if we see any questions they might want to ask, we'll follow up. Don't worry.
Perfect. So what is oral health related quality of life? We understand this as a latent variable. And oral health quality of life can be understood as the extent to which oral diseases affect the functioning and psychological well-being. That's our classical definition from David Locker in his paper in 1988. How do we measure functioning and psychological well-being? And it's not any psychological well-being. It's let's say, the impacts of psychological well-being because of oral disorders. The oral disorders are the causes of quality of life, which makes sense, right? That's the cause. So we should not actually try to validate an instrument based on that, because we assume this is the cause. But well, we know that a person may have low quality of life as physical, psychological, or social functioning, because we have some indicators of low oral health related quality of life. When people have low quality of life, they stop smiling. And here is speaking, not speaking. So people, they change the way they speak, or they stop speaking. They refrain from brushing their teeth. They don't go out. They don't kiss. They don't eat. They feel embarrassed. They do not relax. They do not sleep. And they may not even do anything in your life. So just stop doing anything, because quality of life or oral health related quality of life is such a low stage that you have all your energy drained. So that's a lot of consequences of low quality of life. And we turned all of these things into items. So we phrase and asking people, do you blah, 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 blah. So we have a lot of these questions that represent physical, psychological, and social consequences. But again, feeling embarrassed, which is one of the consequences of low quality of life, is embarrassment. It's not quality of life. Quality of life is the sum of all items. No item on its own could indicate quality of life, correct? So that's a holistic view, that quality of life is only the sum of all items. All items together, they have a different meaning that they have on their own, okay? So we have a lot of instruments, a lot of measures in oral health related quality of life. Some are generic and some are, as we call, condition specific. And what I'm going to talk now is more mainly based on one of our papers from Federico Riva, which was my master's student, a very good one, and Mariana Sewani, they did a very great job. We did a systematic review of all papers on quality of life, oral health related quality of life. The objective was to look for the theoretical models and how many instruments we have. And it's set to go on its own. What we found was a lot of different instruments. They read throughout the papers, they looked for the references, and they looked for the references of the references to see what was the theoretical model based. We found almost 400 validation papers. So we look for all papers about validation. We should do validation as one of the important results. And out of 400, we found 42 original instruments. So we have a lot of instruments to measure oral health related quality of life. And from these 42, Locker's framework was the most common. But overall, out of 42 instruments, we have 74 versions. I mean, just think about OHIP. OHIP 49 is one, OHIP 14 is another one, but you have several versions of OHIP. OHIP Dent, OHIP aesthetics, and so on. But we also split these 74 versions into generic and condition specific. So 34 condition specific and 40 generic. The three most common instruments, as we could predict beforehand, was OHIP, GOHAI, and OIDP. But I should highlight also that even among generic instruments, there was no agreement on the number of domains or the domains itself. Here is our picture from all the theoretical models. And here we have centrally Locker's conceptual framework, which led to the development of GOHAI. It also led to the development of OHIP and also OIDP. OIDP in this case also got some input, theoretically speaking, from the Resines-Sick role of Parsonian, which came from the Parsons theory of how the patient behaved before the 70s, so like in the 60s, 70s. So we traced back different theories for all these quality of life questionnaires. And we have, after the year 2000, still a lot of new instruments being developed. And from this point on, most of the instruments are condition specifics, like this one, which is the orthognathic quality of life questionnaire. This one is the family impact scale. And then you have lots of instruments that are very specific, but most of them, directly or indirectly, they came from Locker's conceptual framework and sometimes from some other theories. But yes, if they want to measure the same thing and they have the same theoretical background, how can we explain that they have a lot of different items and a lot of different dimensions? Here we have one of the tables in which we have specific instruments, but the generic oral health related quality of life instruments are not very different. Here we have, for instance, the first one is the temporomandibular disorders. Another one, which is the impact, to look for the impact of removing impacted lower wisdom teeth. the orthodynamic quality of life questionnaire shows Tomia quality of life, fixed prosthodontics, OHIP-EDENT for edentulous patients, and then you go on with oral facial pain and disability. This one, the Manchester Oral Health Pain Disability Scale, have only 2 dimensions, which is the physical and psychological. But if you look for the OHIP-EDENT, the full version, it has 7: physical or functional limitation, physical pain, psychological discomfort, physical disability, psychological disability, social disability, and handicap. How do we explain so many different dimensions based on more or less the same number of items and based on the same concept? Well, you could think that you have several houses and they have different number of rooms. The bathroom is not always in the same place. The kitchen is not in the same way. It might be together with the living room or be in a different part of the house. So we can explain these differences. They are different instruments overall, right? But it also means that we need to understand better the differences between all these instruments. Because, again, they want to measure the same construct, right? Sometimes with the same items. Because if you look for the items, it's just different ways of rephrasing the same things. Some of the dimensions are actually the same. So we could actually put an eye on some of these instruments. And okay, is eating an item or a dimension? If it is a dimension, not one item, could we put this as physical dimension? So we can develop better our conceptual model because we have a lot of differences. We can talk more about that. And perhaps if we wanted to improve the current instruments, then we have some room looking for this state of art. What is also interesting is that from the very beginning, most of the validation of those studies is based on external validation. You can see here in the 90s, 58% of the validation publications, they were based on external. External is associations of quality of life with other constructs. Let's say anxiety is another construct. If I want to validate my oral health related quality of life instrument, I want to correlate with anxiety. If we have some correlation, thumbs up, it's validated. Not quite like that. Because external validation is not very good and should be the last one to be done. And you need to be very, very sure about the result you want. For instance, if I develop a racist scale to measure racism, and then I found out that white people, on average, have more discrimination. Well, it's because the instrument is not valid. So I anticipate the result, which should be obvious, and it's not scientifically on debate, right? So external validation should be very, very, very clear, right? So that's why it's not actually the first way to do. We should actually first look for internal validation using mostly factor analysis. But still nowadays, internal validation is not the most common way. And we have a lot of validation studies in the last 5-10 years, mostly from validate these new instruments based on condition specifics. But also, then I'll go to the next step, which is if we want to use these instruments all around the world, we need cross-cultural adaptation. And it has been increasing over time. So from 8 to 35% of the validation studies, they concern about cross-cultural validation. But then I would ask, is 35% enough? I would expect more, but I might be wrong, of course, because you don't need to validate 10 times the same instrument in the same country. So let's see the adaptation to different settings and different cultures. This is something that Mateus would be talking from now on. So I'll try to understand and guess his slides, okay? I wouldn't guess what's this, but of course, this impacts the quality of life. I think everyone would easily agree with that. What are the consequences of dental caries? But dental caries, or the diagnosis of dental caries all around the world is the same. We use the same criteria, and dental caries in China, in UK, in Brazil, or in Hawaii is the same diagnosis, is the same disease, it's the same concept. We can see dental caries. It's not an, you see, this is not an abstract and subjective construct. It's something very, very clear. So we can do the same diagnosis all around the world. But we cannot say the same thing for latent variables, which are abstract constructs, right? And abstract constructs in social science, they depend on the values of people where they live. So they are socially built, they are social constructs. So cross-cultural adaptation is the degree to which the performance of an item on a culturally adapted from, which is the patient-reported outcome measure, is inadequate reflection of the performance of items in the regional version. So doing cross-cultural adaptation is actually doing another instrument which is exactly the same as the previous one. It's a very difficult task, very, very, very difficult. And when we say the item performs equally, so the performance of the items is actually the same, it also means we have similar items. Let's think about an item which could be an impact of oral health quality of life, which is kissing. Do we kiss each other? And then we're going to say, wow, but it is highly defined by the culture. Because people, in some countries, they kiss a lot. In other countries, they don't. Can we kiss each other easily in your country? How does it work? I'm pretty sure it's not the same everywhere. So if we have one item about kissing, it's going to be very difficult to adapt from one country to another country because the culture is different. People do not accept. And sometimes people don't even kiss if you're not very intimate. You need a lot of intimacy to do some kissing. Okay, so the best way to do is to remove this item, which could not have a substitute. Do we have a substitute for kissing? Perhaps no. So we leave the instrument without this item because we cannot, adapt from one country to another. But I'm talking about country and culture and social values. That's one part of cultural adaptation. We should also consider, which is the first thing, is the language. So the language changes are cross-cultural adaptation. The country, social values. But we can also think of cultural adaptation within the same country if we look for different groups. I mean, let's think of the punk groups or people on the right wing or left wing. They behave differently. They have different values. They not only eat different food, they dress in a different way. They speak with different words, even if it's the same language. They have different values. So they don't behave in the same way. And it's the same country, same language. It's just two groups, let's say, religiously based, politically based, socially based, music, and so on. So we need to actually think, do we have items that are universal or not? I'm going to just skip this and come back again. There are many guidelines for cross-cultural adaptations. Okay, many. Can you guess how many? 31 guidelines. It doesn't make our life easier. These things, I mean, sometimes we want some help, and then the person said, yeah, just pick one, 31. But what's the best one? Not easy to say. Not easy at all. Let's see two main ones. The two main cross-cultural adaptations, ways of doing in let's say dentistry, but not only dentistry, is looking for a couple of papers from Dorcas Beaton and Claire Bombardier. One is this one, the guidelines for the process of cross-cultural adaptation and self-reported measures. And the other way, which I actually, those who know me already know, the one that I like better is the Herdman one in quality of life research. It's the model of equivalence in cultural adaptation of health-related quality of life instruments. It says universalist approach. So what are the differences of these two ways of, doing adaptation? The Beaton paper, which is highly cited. Yesterday, I just checked it. In Google Scholar, it has more than 13,000 citations. So people, they use a lot. And it's all based on get the original version. Ask permission for the authors, of course. And sometimes it's pointless because, they have copyright. So you cannot use at all. And only the original authors can do cross-cultural adaptations because they have the copyright. It's patent protected. But I mean, in oral health related quality of life, I have knowledge of no instrument which is protected under copyright, which is good sometimes. And it's bad on the other side because we lost control. How do we explain 74 different versions, 20 versions of OHIP? Sometimes some of those OHIP scales are not OHIP at all. They're a different scale. When you start changing the number of, all OHIP versions should keep the same instrument construct. You see, if it says 7 dimensions, it should always have 7 dimensions. You should not change it internally, the instrument. If you change it internally, the dimensions, then it's not the same instrument. But well, anyway, that is just some brackets. So what Beaton actually proposed is get the original and then translate to your language, okay? And then do some, qualitative or very basic qualitative analysis based on the translators, the reviewers, right? And then you do some back translation, right? And then there's this tricky thing, who should do the translation and back translation? Native from the regional language or someone which is native from the language to which the instrument is going to be translated. And after having these two versions with some differences, then you go through a expert committee, right? Which is going to say, okay, blah, 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 blah. But one point here is there's no conceptual equivalence. You see, the Herdman start with conceptual. Do we have the same concept? Do the same concept exist? And when you go to social sciences, some people are going to say, no, we don't have this concept here. Yeah, it's some concept that we don't have. Is it possible? Yes, of course, because concepts are totally a social construct, right? And who should do that? Well, you should, of course, as Herdman says, talk to people, do a lot of qualitative research, and get some anthropologists and sociologists to social science. We are dentists. We are not, it doesn't matter how much I study sociology. I'm never going to be a sociologist. I'm going to be a dentist with some knowledge of sociology. It's not the same thing. But then you should look to item equivalence, okay? For instance, here in South Brazil, we have borders with Uruguay.
Hi, Roger.
Yes, please. Yes?
Oh, sorry.
Great, you are in, Mateus. I'm well advanced already. Well,
Now,
take the lead.
Oh, thank you, thank you. So let me just see where we are. So perfectly, guys. So sorry for the issues. So basically, my name is Mateus Perazzo, and as Roger have been saying, he's talking about Beaton, right?
Yeah,
may I share,
comparing both.
Roger? There is some issue if I can share, because I see that the screen is a little bit crazy.
Yeah, I use Ubuntu Linux, so not many people use this system.
Yeah, so I
mean,
so
would you like to share, or
can you see my screen?
I have to stop mine first. Just... Oh yes, great. I can see your screen, and I guess everyone else.
Perfectly. So I would like just to say, okay, that we have many guidelines, 31 guidelines for cross-cultural adaptation. But essentially, there are two lines for cross-cultural adaptation: the line from Beaton and the line from Herdman. Which is the difference between them? I will summarize it. Probably Roger already did that, but let's see again. So Beaton understands that there are two big different steps. First, the cross-cultural adaptation, and then the validation. Probably you already saw those papers with the title Cross-Cultural Adaptation and Validation of the name of the scale, like child auto impacts on daily performances. The criticism for this classification is separates the phases cross-cultural adaptation and cross-cultural validation. Cross-cultural adaptation shouldn't finish on the pretesting, because if we do not have good psychometry indices, we do not have cross-cultural adaptation. So they are dependent. So, well, there are pretty common I'm sorry. I have to say about Herdman. I'm recovering from all the process, but let me talk about Herdman. This issue that Beaton found was solved in Herdman's classification. For Herdman, there is a continuous process of equivalence, from the conceptual and item equivalence to the functional equivalence. So there aren't independent moments for Herdman, okay? Besides, Herdman presented the idea of a universalist approach. This universalist approach does not make the prior assumption that the constructs are the same across cultures. The equivalents are evaluated between the original version and the adapted version, and the focus is not just in the linguistic elements, but also on the whole context. But Herdman also classified, I'm sorry, let me just adjust this. My screen. Okay. So, universalist approach, and Herdman also classified other approaches that do not follow the universalist approach or this universalist conception. Let's see them. Well, they are pretty common in quality of life studies, okay? So, well, let's see how they are categorized. For example, there is the absolutist approach, common among English-speaker countries. For the absolutism approach, there will be a negligible change in the content of the concepts. So a careful attention to linguistic elements will make a questionnaire acceptable for use in another country or in another culture. There is also the relativism approach. Basically, in this relativism, it states that each culture should have its own instrument, but that's not practical, especially considering the theoretical base of quality of life. In this scenario, we would have tons and tons of different scales. Roger, do you have a good reflection about relativism, right?
Yes. And just to add a point, the idea of absolutism approach is solved because you removed items that are culturally sensitive. I mentioned before the kissing item. When I was going to say, I live in the south part of Brazil, border with Uruguay, we drink mate or chimarrão. You could have an item. Have you stopped drinking your mate, which is a way of socializing with people? And then you're going to say, yes, my quality of life is so low that I stopped drinking mate with my friends. But this wouldn't work in any other part of the world, apart from Argentina or a few countries. So they just remove, and then it seems it's all solved. But if you need an extra item, you cannot use that extra item. So you might get some problem, get some shortage of items with this strategy. But the relativism approach, which is no, there's no way to adapt an instrument, right? We don't see them because they live in another bubble. We live in one bubble in which we go from universalism and absolutism approach. So we work with these things. But if we go to some anthropologists, and I have some around here in my university, I was talking to them, and then we were talking about social capital and social cohesion. And then at sudden, the woman, very clever, said, yeah, it's totally constructed in different parts of the world. It's not the same thing. You cannot adapt. That was really categorical. And that's how they do. So if we look for them, or the papers on, let's say, social capital, social cohesion, in some of those papers from anthropology or sociology, you don't see any validated instrument because they don't believe it's possible.
Yeah, it's true. That's an important question. So I will show you now some results from a bibliometric study from my research group. We investigated the 50 most cited cross-cultural adaptations of pediatric oral health related quality of life instruments. Here, I would like to focus on the reference used to perform the cross-cultural adaptation. Most of the papers did not report any guideline as reference. Besides, we identified some misunderstandings for those cases that cited Herdman or Beaton, because in some cases, those papers cited Herdman's theory, but they were actually using Beaton's theoretical basis and vice versa. All these non-standardization, misunderstanding, excess of guidelines are the concerns for having good cross-cultural instruments. And this concern is not just for use in another country, but if you have a specific population group in your country, you need to adapt the instrument for that population. But before finishing the discussion about cross-cultural adaptation, I would like to ask a question or a reflection. Do you believe that we can compare the cross-cultural adaptation results with the original version of the instrument, or do you believe that we can compare two cross-cultural adaptations from different countries? There is a common sense. We can compare constructs as long as they are evaluated by the same questionnaire. We usually see that on meta-analysis. However, it's not adequate. Using the same questionnaire in different groups doesn't mean that the score are comparable among different groups, or even if they are measuring the same construct. Vector loadings, intercepts, errors may be not equivalent. Consequently, they are not comparable. So how can we check? How can we evaluate the equivalence among groups? Just test the measurement invariance that we can test the equivalence among groups. In other words, the measurement invariance is an empirical approach used to evaluate the equivalence among constructs. If measurement invariance is not tested in a cross-cultural adaptation, there is a chance, there is no assurance that the instrument is truly assessing an equivalent construct of oral health-related quality of life as the original version. Likewise, researchers cannot safely conduct cross-cultural comparisons. Despite the relevance of measurement invariance, it's still not usually tested in cross-cultural adaptations in dentistry. If we do not test measurement invariance, there is a chance that we are comparing apples to oranges. In other words, doing useless or dangerous comparisons. Therefore, caution is needed when embarking in oral health-related quality of life comparisons, especially in meta-analysis, because we usually don't have the evidence about equivalence among those constructs. Journals should reinforce the relevance of conducting measurement invariance of well-developed scales, and then a net of solid sources of evidence will be cumulatively created. Okay. Roger, do you want to say something about the topic?
Yeah, I mean, I think you
Please.
raised a very important point. Sometimes it's overlooked. And of course, it doesn't mean that all systematic reviews in this field should be thrown in the garbage bin. Of course not. I mean, I work in social determinants, and sometimes we use education, sometimes income, sometimes occupational classifications. We are actually also mixing different things because education is not the same as income. If the results are the same, then we have a robust result. Okay, we can interpret, but we need always to be clear that, well, are we mixing different things? Because sometimes we have a lot of heterogeneity. Sometimes the results are not the same, and we need a good explanation. And this could spot all a new world of research, perhaps.
Yeah.
I mean, just think about the Peru guys who change the classification of periodontal disease every time, and then you do a systematic review with, in the last 40 years, so with 10 different definitions of periodontal disease, and then someone says once, well, the most important variable that changes the prevalence of periodontal diseases or any disease is the concept. That's what we are talking about here, right?
Yeah. Measurement, we have to advance in this analysis. So, okay. Next topic. Now, let's focus in this important topic called practical tips to psychometric evaluation of the instruments, or practical types of psychometric evaluation of instruments. Considering the possibilities that this moment provides for discussion, as we are doing, I would like to start by talking about an important topic that is very little discussed in the scenario of measuring quality of life, which is the conceptual evolution of validity. The definition of validity was always published on the book Standards Education and Psychological Testing. The standards is sponsored by the American Education Association, the American Psychological Association, APA, and the National Council on Measurement Invariance. The purpose of the standards is to provide criteria for the development and evaluation of tests to provide guidelines for assessing the validity. The history of standards is relatively long for the young field of psychometry, dating back approximately 70 years. The conceptualization of validity provided in these standards evolved over time. I summarized this evolution on the graphic. Although there is all this evolution, in most quality of life studies, we still are using the concepts from 1985. For reasons of time, I won't focus on the current framework of the five sources of validity. I want to focus on the current definition of validation. So the new concept for validation, what is validation? Let's see the current conception, okay, the current definition. So the process of validation involves the accumulating relevant evidence to provide a sound scientific basis for proposed score interpretation. Therefore, statements about validity should refer to particular interpretation for specified uses. This new statement shows how the validation process is continuous and constantly evolving. There isn't a validated or non-validated categorization. It's incorrect to use the unqualified phrase, the validity of the scale, the validity of the instrument. When we saw a questionnaire that a scale is validated, it gives the idea that it's complete, it's perfect, it's validated. Actually, there is a process of a continuous and accumulation sources of validity evidence. Hardly ever we see standards being cited in quality of life studies. It's more common we see researchers using COSMIN. Yeah, COSMIN is an initiative of an international multidisciplinary team of researchers with the mission to improve the selection of outcome measures instruments of health outcome by encouraging the use of transparent methodology and practical tools for selecting the most suitable instruments. So basically, we can access the website, download the guideline, and check the boxes. Consequently, we can see if the quality of life instrument has a good sources of psychometry evidence. Unfortunately, again, COSMIN considers the 1985 concepts from standards. Besides, it embraces some old-fashioned practices to evaluate reliability, sample sizes, internal consistency. Still, COSMIN is very helpful in evaluating quality of life. Ideally, we need to advance. Join COSMIN and the standards. Have an updated and complete guideline to be used in quality of life studies. Roger, please.
No, totally agree with you. Totally agree. And then, in one of the things that we need to advance more is how to interpret the scores. We sometimes just, throw the numbers and people, they don't interpret. Perhaps people from like lab studies, they are used not to interpret. You don't interpret the log of some lab results. Yes, can you go to the next? Yeah, so, but I mean, here we can and we should actually try to interpret because it needs to be meaningful. And I actually try to, I see three main alternatives to interpret our scores. And I will start with one example from other fields. In mental health, there is one well-known questionnaire, which is the General Health Questionnaire, the GHQ. There are different versions. One of the versions have 12 items. And this questionnaire taps minor psychiatric disorders like anxiety, insomnia, things that happen in our daily life, okay? And then they said, okay, if you have more than 3 points, you are referred to doctor. You should see the doctor because it's a screening questionnaire. It's not a definite diagnosis of mental disorders, which is currently fine. But then you could say, yeah, but who said it's 3 points and not 4? Yes, it's very arbitrary. And no one is sure the 3 is the best. But at least it's a guide. If you have more than that, then you can take an action. For clinicians, that would be perfect. That's why the clinicians, they use the GHQ. Let's think about our oral health related quality of life. Do we have any usual cutoff point? And the answer is no. But at best, we can cut on 0. And then we have the prevalence of the impacts. For instance, group A has 40% of people with more than 0 points. So they have at least 1 or 2 points in the scale, so they have some impact. So oral diseases impacted, so they have some quality of life shortage. In group B, it's 45%. So 5 points difference is something that we can interpret, but that's prevalence. And group A, which has a lower prevalence, might have a higher intensity, and we don't know. But I mean, at least that's one interpretation. It's easy to do. That's perhaps one of the most common ways to interpret our instruments. So let's go to another alternative, which is based on minimally important difference. And then I put here this paper, which I think is fabulous. It's not new, but it's still very good. I guess it has a good, I mean, for those who are, first time looking at this, it's very clear from George, and I think George is here, but he was trying to get before and was not able. So it's how to interpret oral health related quality of life, which means what we are talking about now, it's nothing new. It's nothing new at all. So next slide. Yeah. So let's think of the OHIP scores. Everyone knows OHIP scores. It doesn't matter if it's 49 or 14. Let's think of a person with a score of 28 points. Is that a lot or a little? Does this person with 28 points has a bad quality of life or good quality of life? We don't know. It's minimum. It's not saying, okay, I have 70 kilos, which, I mean, it's so easy to understand that we can translate to other metrics like, ounces, I have so many ounces, or pounds, or whatever. We just, you can easily, it's physics, right? It's weight. 28 points is not the same thing. We might interpret looking for the range, the minimum and the maximum. Okay, if the maximum score is, let's say, 56, then it's half away. So it's middle. Yeah, but still, I mean, translating percentage, looking for the whole range, yeah. You have to do this for all the instruments. But let's think also in another way. You have your score, I mean, the same slide, the previous one. You have the same amount of points, then the clinicians, they treat the patients with some specific treatment, and after treatment, the patient, on average, they improve 2 points in the scale of, let's say, OIDP score. Does it mean that the treatment is good or bad? Is that enough to improve 2 points after treatment? I mean, then it's hard. And it doesn't matter if you put in the scale from the maximum and minimum, it's a lot or it's a little. There are two common ways of setting minimally important differences. One is based on standardization, on the distribution of the scores. Then you get the mean and the standard deviation, and then you can calculate effect size. That's one. So I'm one standard deviation above the mean. So it's kind of a lot, I would say. Those who know statistics, but who knows that? I mean, the clinicians and patients can understand easily this? Not at all. Not even some researchers can easily grasp this idea. And then also there's this anchor-based methods in which you set a reference patient. So I have this patient with this profile is, let's say, a woman, middle age, high education, and she answers in this way, and her score is 3. So that's my reference. So everyone with more than that is bad. And I know her profile. So that's more or less how we anchor in one score based on the patient. Can be useful, but very difficult because different scales, different instruments is going to be totally different. And it's not going to be easy to compare. So let's go to the third way, which is based on not looking to the scores, but look into the items. This way, I think it's appealing and I like it. But it's, I mean, you can argue that it's not good because it has a lot of drawbacks, right? Because now you just ignore the score and you attach the meaning to a score. Well, as long as we are cautious with this approach, it may seem okay, different from the current way. And perhaps an example will make it easy for you to understand. Let's go to the next. Yes, so we have 3 drawings here. So the first is based on what we call classical theory. And then we have here, can you see my pointer? No, it's only the Mateus point. Yeah, so the first draw, there's a person who actually endorsed item 1 and item 3. So they are in blue color, yes. So if we sum them, we have a score 2. And then we have another person, and you see the bubble here, that's the latent variable, and then we have the 3 items, and this second person endorsed items 2 and 3. It has the same score, 2. And then you're gonna say, oh gosh, but how can I compare? Because they have the same score, but it's different items. Yeah, but you see, in classical theory, it doesn't make any difference because item 1 is eating broccoli. It's a, you know, like vegetarian scale or vegan scale. Item 2 is eating cabbage and item 3 is eating lettuce. It's all green leaves, green vegetables. It doesn't matter if you eat one or the other, they are interchangeable, there's no order. That's how we look for classical theory, and then we look for the scores. So the scores are comparable, no matter the items that originated that score. But if we look for item response theory, we have a different approach. We look for the items, and then we have a person here who actually endorsed item 1 and 2. They have a score of 2, which is different from the score 2 previously, because now I have to interpret this score based on the items. So item 1 is swearing, shouting out loud, cursing the person, you know, bad names. And then the next step is physical aggression, like, you know, slapping in the face or throwing objects. And of course, in the last phase, item 3 is shooting. So you technically, or I mean, theoretically, you're not going to shoot someone without verbal aggression. First, you're going to say, stop, I'm going to shoot you. And then you don't stop, and then I shoot you. And then I really did it. That's how it works. So no one is going to endorse item 3 without endorsing item 1 and 2. And if the person actually has a score 1, we know that it's 1 because there's only one way to get a score 1, which is verbal aggression, you know, swearing. But we could have different items. I mean, shooting is one item, but it could be stabbing. So that's why we should not actually attach the score to an item, because an item represents something. And we can change, we have several different items for this place, which we will call the theta score. So shooting is one, but stabbing another one. And if you can, you know, think of different ways of killing people, you can change item 3 to any other way of killing people. You know, like, you know, hanging or, you know, just think, I mean, I can't think of, you know. So let's go for next slide. So then I took the OIDP. Does it work truly as a Guttman scale? Perfect one? No, of course not. We would never, you know, ask a real scale to behave as a true Guttman scale. But I put here all the 8 items in order. And you can see that the item 1 is the easiest one, is eating. Have you changed, you know, the way you eat? Yes, I have changed it. So 7.9% of people said yes, they changed it. That's the most common way. And among those who have a score 1, which is the second column, to have, if the person, and you have several people, if those people with a score 1, it's because they endorsed eating. That's the first thing that happens when you start losing your oral health related quality of life. 40% of people with score 1 said eating. And then smiling is the second most common, and brushing is the third most common. And no one should perhaps stop doing sports or going to work because they have minor problems in their quality of life. So they go to work, they go, they go to school. They don't stop going out. Only 0.9% of people, they stop going to sports just because of that, because of low quality of life. But we have very few people with a score 1 because they scored that item. Then if you increase the number of points, and here we have a maximum of 9, if you look for the score 8, we see that those people with score 8, 97% endorse eating, which means everyone with this high level of quality of impact, it's because they stop eating or change it. So we have an order. It's not perfect, Gutmann, but okay, so now I can understand in a different way a score, how much your quality of life can be impacted from more physical to psychological and social issues. So we have the easiest, from the easiest to the most difficult scores. So that's one thing that we can develop, because then we may interpret these scales in a different way. Let's go to the next slide, and then we have applications in real practice, right? Matheus, I mean, would you like to add something more on this interpretations? I mean, you work a lot.
No, I think it was very complete. I'm okay with. I will advance.
Yes.
So with applications in real practice, okay? So finally, we're going to talk about applications of oral health related quality of life in real practice. Let's start with this brief last part of my presentation with another question, another reflection. Are we evaluating oral health related quality of life in our practice? So we talked a lot about quality of life today. I like to compare quality of life to the artistic painting technique of the late 19th century, the pointillism. So in pointillism, a dot is important, but it contributes little when taken out of the context from the whole, right? In dentistry, the mouth is our dot. If we decontextualize it, it's also difficult to understand the whole. Quality of life is undoubtedly essential. It has to be a priority for clinicians and researchers, but sometimes it's not a priority for our patients when compared to clinical approaches. Why? So let's continue with oral health related quality of life. That's a construct that includes the impact of oral diseases on functioning, psychosocial, and general well-being. If the functioning is impacted by oral conditions, quality of life may be negatively impacted by poor oral health. Such consequences, however, need not to be the result. There is a poor oral health may not be perceived as indicative of a poor quality of life, depending on how much an individual values their oral health. So that's the reason we need to consider the concept of oral health values, OHV, oral health values can be defined as the extent to which one views dental status as important, or one's prioritization of improving or maintaining one's oral health. The small size of this literature suggests that oral health values are understudied as compared to values related to other aspects of health. Oral health related quality of life is related to oral health values in that both involve perceptions of dental conditions and dental related concepts. As has been discussed by Locker and Allen, many health related quality of life measures are criticized because they reflect the concern of clinicians rather than what patients value. Locker and Allen suggested what is missing from most measures of oral health related quality of life is acknowledgement of value systems and a comprehensive assessment of impact that takes into account relative importance of orofacial functioning. I hope in the future we will have more researchers groups about quality of life and values. It's not just what we believe that is important, it's also what our patients believe. And we will never focus just on the mouth again. Thank you. Roger, do you want to say something about?
No, Blas, thank you. And for the audience, we are sorry this technical issues. I mean, I had an not updated version of the slides. So in the beginning, we had some spelling mistakes in the slides, which are recorded.
Thank you, Roger and Matthias. This has actually taken me back to the time when I was supervised by George Stakos for my MSc, which was related to child OIDP and validation in a UK population for 10 to 11-year-olds. So this has been a blast from the past for me. Can I bring in George? I think he has managed to log in.
Great.
But I can't see him at the moment.
Well, a lot of people.
Oh,
yes.
Hello, George.
Hello, how are you? Yeah, I've managed to log in. I've missed half of it though, I'm sorry. But the one I managed to see was actually a real treat. Thank you both very much for that. I think it's probably the best thing to do is to open up for the discussion and see if there are any points. Should I start with, we had the European Association of Dental Public Health last week had its annual Congress, and there's special interest working groups on that. So, and we had the sort of think about what could be relevant questions without seeing your slides. So a few of the questions you've sort of answered. So should I pose a couple and then you start the debate and then other people can join? And I don't know what would be the best one to start. I think I do. How would you determine a cutoff for a good or poor quality of life? You said about how you interpret the scores, and you gave us a set of different options. And I'm not saying there's a good answer to that, but a number of participants in the conference were saying, I get these scores, and I have no idea how I can go about it. And I said, well, hang on a minute. In a few days, someone else can answer you. So, have a go.
Yeah. Well, first, if it was an easy question, people would have an answer from many years ago, right? So we are still, like in the middle of the woods, trying to get out of it and making a path. But my guess is these instruments, they need to be useful for the clinicians, right? So two issues here is, shall or would be the best possible situation is the patient get 0 score. no impact whatsoever. So the goal of the treatment for clinicians would be to get no impact at all. And that's the perfect issue. Okay, is that a dream or mirage, or, but that's perhaps the easiest way to interpret and the easiest goal to agree with. But then you would say, okay, 1 point could be acceptable. Yeah, 2, 3, 4, we don't know. So I don't think, I mean, now what I'm going to say is not because I'm pessimistic, but I mean, in other fields, like mental health, psychology, they don't have good cutoff points. So I don't think we are going to get to one good cutoff point. What we could have is to get like a screening instruments, which we don't use these quality of life instruments as a screening issues, right? But I mean, when they have screening instruments, then they use cutoff points to refer patients, like, you know, alcohol scales, you get X points, then, okay, you are drinking too much, I mean, you have trouble with alcohol, so go to the doctor. That's not our reality. So I don't think we will ever get a good cutoff point for that. So can we live with that? But I mean, as long as we can improve the interpretation of the scores, then we can improve. And going further on psychometrics, I mean, and Mateus is good on this hard psychometrics or item response theory and so on, then we perhaps can give a different perspective on interpreting this course. And I know, George, you should be answering this because you are the guy who I read most about that.
Okay, yes, we can live with that, is my answer. We can live with anything. We don't die from lack of oral health-related quality of life. No, we live from it. But in essence, you do realize, and Mateus, please join on this, you do realize it's an issue, not so much how dental public health community views it, because we are living with that sort of uncertainty. You take decisions without having absolute certainty about black and white. Yeah, we're more familiar with living with a variation of scores. But you do realize that when you both said we need the scores to be very relevant also for our clinical colleagues to help them with the decisions, suddenly we ask them to move a little bit out of the usual binary mode, which is disease, no disease. Similarly, they want to say good quality of life, bad quality of life. And related to that, if I do an intervention, and you mentioned a little bit of that, how do I measure the change? Is it at an individual level as a clinician, or do I look at the population level? Do people adapt? How do I account for this?
Yeah.
I don't know whether you or Mateus want to comment on that.
Would you like to go, Mateus?
No, go first, Roger.
Yeah. I mean, for clinicians, of course, they need to go for the individual patient, right? And perhaps my guess is, well, if you don't get 0 score, get the lowest possible, right? I mean, it's like, I mean, I was to my endocrinologist a couple of months ago, and then he said, oh, my, glucose is could go down. And then I said, yeah, but it's not that bad. I mean, the cutoff point, internationally is set much upper. Yes, but try to get even lower so you get far from the cutoff point. And then I realized, yeah, for the clinical, for the clinicians, the patients, individually, get the lowest possible safe way. But on research and public health, then perhaps a small amount on average is important. I mean, more or less in the same way. If some treatment improves in only 1 point or 0.5 points, I would be happy. I mean, if it decreased dental caries by 2 to 1.9, it's very little. It's 1/10 of teeth, right? But we are happy because we are going down less caries. So I would be happy even with very small amounts, improvements in the overall score on average. Let's say, let's put fluoride on water, and then the quality of life score decreases by 0.2 points. I would be happy too.
Yeah, it's true. And maybe we have to consider those auxiliary constructs like values as well, because if someone there is no a low value for his oral health and all of the one has a high value for oral health, how are you gonna treat that? How are you gonna face these different situations? Because sometimes someone there is no value for his oral health, terrible conditions, dental caries. Someone else is different, good, or so there is a universe of constructs. I believe we cannot just focus on quality of life for consider even those point of cuts. I think it's more a structural process, but yeah, I don't know if you agree with me, Roger, but I think we cannot just see for quality of life in this case to prioritize, to give a prioritization of treatment or in clinicians, researchers. Anyway, I think it's more broad than what we believe.
Yeah, no, definitely. We can introduce all these scales in different settings.
Thank you both. Can we open it up? I have more questions. I see Barbara has put a question in the chat, and I will read it. But there might be other questions, so colleagues might want to intervene. The question in the chat is, are these concepts that you explained in relation to oral health-related quality of life also transferable to other related constructs, such as knowledge and attitude of care staff, oral health literacy, etc.?
Definitely.
So now that you bombed quality of life field, do you want to bomb with subjectivity the whole, basically?
Yeah, I would say definitely, Barbara. And I mean, I have seen oral health literacy instruments being published, and the process of validation is ongoing. They are promising, and other latent variables that we have in oral health are very relevant, and we perhaps should think of using more and more latent variables in oral health, because we are stick too much perhaps to some concepts from the lab. I mean, at least here in my university, people that go to the lab to study things instead of going to the patients and looking for patient-reported outcome measures, which I think is the most important measures are those reported from the patients and the people.
And just to consider that those constructs are different, like knowledgement is a formative model, literacy a reflexive model. So there is those differences, but in general, we can apply the same concepts for them.
Yeah, and if I may add to this, I think sometimes it's an issue in our minds rather than in reality. So we expect, and as you will also of us have clinical colleagues that suddenly quality of life measures in the last decade have become so popular as outcomes. And it's like, if we can demonstrate this, we've shown it works. Well, and you have to explain, I think. We have to enter a debate and say, well, what you have shown is that the person feels better that it works, but that's a more comprehensive decision, and it's not going to be based on 1 point here and 1 point there. And in a way, I'm trying to think in the applications that you referred to. One is the clinical application and the needs, but there's another big application, and Lotte has picked it up years and years back when he talked about political applications. What I would talk now about advocacy. So we live in a window of opportunity for oral health, everyone speaks about oral health, not just us. You know, you have the WHO, the Lancet. Everyone has something to say about how important oral health is, and Roger is in the Lancet Commission and the series of papers, so he's responsible for that in a way. It means that those measures are being used also as outcomes for advocacy. I see Paula there. I mean, a lot of the times when you go to speak to someone in the political bubble, and you go and say the DMF score is this, you get the sympathy, but you don't get any movement because it doesn't mean something tangible. The minute you start talking about symptoms or they haven't slept and the quality of life has been reduced suddenly, they engage. And I don't know whether we can have the same measures being good for clinical practice, good for risk assessment, good for advocacy. It's like a silver bullet suddenly, you know, we found the solution of all problems. I think we need to probably accept that they have important limitations and treat them for what they are. But the advocacy issue, you haven't touched on it. And I would like to pressurize you a little bit. And can you think that these measures, with all the issues that you raised, and all the positives that you raised, because you also given us what we should do next, how would they fit in a WHO Global Action Plan? Well, what's their role? Why should the ADPH or any other public health organization bother? Can they be used for advocacy?
Yeah, very interesting issue. I mean, just theoretically speaking, can we improve patients' reported outcome measures like quality of life without reducing the DMFT? If the answer is yes, I mean, it would be strange to get one up and the other down. They should go in the same direction. But I mean, if we can improve, it means, yeah, they are showing something that hard measures of DMFT cannot show. I mean, you may have feeling and no other dental caries, but you don't feel like right. I mean, it's not well. So we can improve quality of life without changing the DMFT, just, you know, making the feeling better. You can improve quality of life in several other, you know, ways, allowing people to smile and engage in going out, because in the end, that's the important thing. Why should we get worried with some teeth that are not so white as we want? So, I mean, I think we can and we should use more of this. But then for advocacy people, they will not, of course, use the scores, right? So they would pick up one item or two items, which is easy to understand. So, but that's, I mean, that's fine, as long as we don't have a distorted advocacy.
Yeah, I completely agree. Sometimes for poor countries, I think sometimes some questionnaires need to be more specific for harder situations, maybe for quality of life. Don't know if you agree with me, Roger, but sometimes we are in a trend to do more short versions of questionnaires, quality of life questionnaires, and ultra short version. And with any reason for that is time, just time. We forget it totally, the construct. It's just time. And we are now in a one item version to evaluate quality of life. So I think we have to see first all these issues, how we are treating, how we are facing the process of evaluation of oral health quality of life related to quality of life, and then see, okay, our prioritization is the construct before time or anything else to do something more appropriate about quality of life.
And one thing to remember now, when you said one item, I mean, we could perhaps use one item, you know, the general item. How do you see, or how do you feel your mouth? And then you have 5 points Like, okay, my mouth is very good, my oral health is very good or very bad, which is, mirror this medical item, how good is your health compared to people of your age. And then in the Lancet Commission, we were looking for oral health surveys around the world. And guess, they don't have it. They don't even have the one item, reported from the person. So we don't know the amount of, very, very few countries, they included self-reported oral health measures in their oral health surveys. We are still a lot concentrated on the MFT, which is more difficult. So why should we go for the difficult thing and skip the easiest thing? But we still don't even have the one item. That was striking because some of our commissioners are, medical doctors going around for general health service, and then they said, we have a very standardized question, one item for general health. Why don't you have this for oral health? I'm pretty sure, Georges, the advocacy would be easier if we had that figure.
And passing the floor to Huda, just to say that she downplayed her work before is probably typical, though it's not the first time it happens, because actually that classical theory validation, the one we all say it's not adequate anymore, but at the time it was the only thing we were doing, has led to a validated child OIDP, which now is part of the National Survey of Children in the country. So I don't want us to leave it and say, well, it's all problematic here, but little by little you make change. So someone like Huda validated it, then other studies used it, and eventually they realized, well, actually we need it in the national survey, which has also the overall question you asked, but you're correct. In some countries exist, but if you look at the global map, very few. Sorry, Huda, I see your hand and I should have passed straight away.
Thank you, George. So I think there's a real dilemma in a way. Academically, we're trying to ensure that we're using validated instruments, and we're quite rigid with that. Yet on the other hand, we're trying to highlight needs to policymakers. And that makes it really, really difficult because of the burden of the instruments. And also, we have had limited research in developing valid instruments for vulnerable populations. And I was thinking about health inclusion groups, as well as, Gypsy and Roma travelers, refugees and asylum seekers, and those experiencing homelessness. And my question to you is, how do we actually ensure that we've got some flexibility in measuring oral health related quality of life with these vulnerable populations?
Good question. Perhaps to be honest, I could say I'm not sure. But we've been conducting some qualitative studies here in my city with homeless people. And then the first thing that came to our minds was, okay, they have other problems. Oral health is not the main stuff. But yeah, for some, but not for all. Many of the people that we interviewed, they said they need the doctor, the dentist, they have problems with their teeth. And then, yes, they could not even get into the shopping or buy something because their teeth are bad. So the appearances, they cannot enjoy going, in normal life. They have to stay in the streets, and people don't look at us because they don't look nice and they don't smell nice, of course. So that's another issue. But then we realized, yes, they are talking about things that you don't need to open the mouth and do a clinical examination. That's a patient or people reported outcome. Then validated issues, right? The more we use, the better we are going to use. I mean, we are now talking about this because we use these instruments. That's why we are talking. And the more we use, I think, the better they will become. And we have, of course, instruments that can be improved. There is room for improvement, which doesn't mean that they are not validated, or it doesn't mean they are useless. You see, they are useful, they have the utility, but we can even improve. And if we get some point a standardized way of measuring, then we go, further in time using the same instrument, and then okay, now we can go and do, let's say, surveillance, public health surveillance using the same instrument. Then it's easier to interpret this course because it's the same instrument over and over again. I mean, in UK you have the same oral health quality of life UK instrument in your surveys, right? Then you can compare. In Brazil, we use an adapted version of OIDP in the oral health survey. And so we have 3 times now, so we can compare again and again.
And that's I'm sorry, George. I would like just to add some information, some point of view, because here in the Northeast in Brazil, it's a poor region, and they, depending of the educational level, we found people that couldn't understand the partial disagreement or partial agreement, as Roger probably said. They don't understand why partial disagreement, but it's not disagree, agree, and don't take a side, basically. So we usually see cross-cultural adaptation, although everything that you said, almost a translation, right? Someone very good created that instrument, let's apply in our context. But sometimes, depending of the vulnerability, we have to create a new instrument, because some levels of depression, it's impossible in a war zone. You apply your teeth, or you have difficulty to eat. So some situations we have to understand that, okay, I have to develop a new questionnaire for this, depend of the level of the vulnerability. So we cannot see everything just plain. Sometimes we need to create, not just adapt. It's the limit of adaptation.
I don't think it's a limit. I think it's an advantage, to be honest. Because, I mean, I think the danger comes from using them almost uncritically. So we can OHIP or IDP or GOHAI anything. And as we do it on a population that is affluent and having no issues at all, suddenly we do exactly the same, going to a population in care homes or going to a homeless population or to a refugee population. They wouldn't necessarily prioritize the same issues, would they? I mean, you wouldn't expect that the context plays no role in life. So it's not just across cultures. It's within a country, within a culture, almost across contexts, that one has to be a bit careful how you can still get some valuable information. But I think Huda's point was spot on. Some of the questions would look irrelevant for some of the people, really irrelevant. And if you ask me an irrelevant question, I lose interest in your survey almost. I think, okay, well, fine. Second irrelevant question, and I switch off. Why wouldn't they? Why? Because we consider them as the less mainstream, which is a really bad term. So I think it's more thinking how we apply them. The instruments are problematic, but not more problematic than anything else we measure. It is us being a bit critical how we apply them and allowing for what you mentioned, sort of the adaptation. And if I can probe you a bit further, how would you do that measurement in variance practically? You told us we need to do measurement in variance. How would you go about it? What would someone need to do it? Let's say in a European context that wants to apply the same 3 questions. We agreed on 3 questions, and we want to apply them across Europe. How would you tell us to help us to do measurement invariance with that, so we know we are measuring similar things or not?
Mateus, would you like to start?
Please, Roger, you can start.
Yeah. Well, first is, I think, to have some basic qualitative study. We sometimes we use very little qualitative study. I mean, sometimes we reduce as a pretest, right, or a pilot, and then we found out things. But then, just to give an example, we were actually looking for discrimination, and then we have a discrimination scale. One of the questions was, have you been discriminated in your workplace? And then we were applying to some people, they were like, you know, they were on social benefits, and they were unemployed, and they were actually but they were working on the streets. So they said, okay, I'm being discriminated in the streets or in my, you know, workplace, because I work in the streets. You know, I'm ambulant, I'm selling things in the pavement. So, okay, we need to adapt to this, because for this situation, you know, the question doesn't have the same meaning, but they were able to give an answer. But answer was like random. It was not correct, because there was no true answer for that question. We found out that we eliminated the easiest way to cross the question. So one less item in the scale. As George said, 3 items, you are likely to get 3 items which are like, let's say, universal. But then you reduce the scale. And when you reduce too much the scale, because you only keep universal items that apply to everyone, no matter the settings, you're not measuring the full concept. So you are missing something. But well, you know, cost, benefit, you cannot get everything, but if you're gonna go around, then that's what you can do. But what if you have 10 items? Some are not, some are invariant. Well, you go in a loop. When you do the analysis of invariance, you're going to spot that one item is not working properly. So you find out, okay, that's the item that needs a better cross-cultural adaptation. You go back to the instrument with phrase, change, substitute, or even eliminate. Eliminate is always the easiest, but not the best way to fix an instrument. Guess what people usually do? They cut items and they get shorter and shorter versions.
Yeah, and adding about measurement invariance, I think when we find that there's difference between constructs, no equivalence, because one country or one group focus more on the dimension of aesthetic and the other one in functioning. Even that we cannot compare them, they are theoretically different constructs. This idea is important to understand those populations, even that we cannot compare as a unique group. So even when you do not have the same construct, I think it's also it's still important. It's still essential to do the policies, even in those cases. I think it's just to take care when you say that they are the same. That's, I mean, the issue, the big problem.
Thank you. Thank you. I don't know if there are any more points. I think it's been a very live discussion. We asked you some very simple questions. What will you do? And I know that some of them simply do not have an easy answer. So I really value the honesty with which you approached it and gave both sides of the argument. Unless there are any further questions, I don't see any in the chat. I think we've tortured you enough for 1 hour and 45 minutes. Could I ask you to, each of you, you haven't prepared that, so let's choose the order randomly and summarize in a couple of minutes what would be the key take-home message. So what would any one of us take, 3 things we should take home from this webinar?
Well, let's think. I mean, perhaps I would say we need to pay more attention not only to quality of life, but we have several other latent variables, because social constructs are all around, especially public health. In public health, we deal with disease, but I mean, we have a lot of social constructs. So we need to pay attention of all those variables, not only quality of life. We have, I mean, someone mentioned oral health literacy, social cohesion, social capital, and then you go on with a long range of, you know, persons or peoples or context, which is abstract. And sometimes we are naive when we try to measure them. So paying attention of all these latent variables would be my main message.
For me, I would like just to, I'm sorry, George.
Yeah. I was passing the floor to you.
And I would like to say, basically, to focus, I mean, give opportunity to standards, give opportunity to psychology, how they face constructs. I think COSMIN is very interesting, but give opportunity to study how the current view of standards, how the psychology is facing constructs, how they are categorizing. And also about cross-cultural adaptation, it's important to understand the differences. We are not the same. We have to understand that there's particularities, and we have to do the best approach, not just translating. It's even for English-speaking countries. You are not the same just because you speak the same language. You have to take care about this. So it's also always is important to take care in how we are cross-culturally adapting and which reference we are using. I recommend Herdman's theory, but Beaton's also provides a good theoretical base.
Thank you. And Roger has come back.
Yeah, I mean, one thing that I remember, and I mentioned in the very beginning, you were not here. I used to read a lot of, you know, quality of life and psychometrics from the dental literature. That was my bubble. And one breakthrough in my career was when I got this people working from other areas like psychology or violence and sociology that were also working with validation of instruments in different perspectives. And then I said to myself, yes, we can do a lot more on dentistry as a whole, as long as we look outside our bubble. I mean, it's very difficult, but I mean, once we get different views, I mean, we change our mind.
I think that's a really lovely point, and I know Mateusz would also agree fully, because I remember when I first met him, he came to UCL as a sandwich for his PhD, but not for dental. He was a dentist. He is a dentist. And he was doing his PhD with Saul Paiva, I think, in Belo Horizonte, if I'm not wrong. And he came and went to psychology, psychometrics department in a way, to get the fresh ideas. So the idea is very good. We call for oral health to be integrated and learn from what everyone else is doing. So why not in different spheres of that? I want to say thank you both very much. It was really nice. I missed the beginning. I'm sorry for technical reasons, but I really enjoyed it. And I want to pass to Huda, the new EADPH president, to finish the meeting. Thank you very much.
Thank you, George. I just wanted to apologize for the technical issues at the start of the webinar. And thank you for an excellent expert-led discussion on oral health-related quality of life. Thank you to Roxana for organizing it, and for George for bringing us together to explore oral health related quality of life in the light of the WHO Oral Health Action Plan. So we have recorded this webinar and we will be uploading it onto the EADPH website. So for people who didn't have the chance to join the webinar, they can watch it at a later date. Thank you so much. Thank you, George. Thank you, Matthias, and thank you, Roger.
Thank you all. Thank you.
Bye.
Bye-bye.
Thank you. Bye.
Bye bye.